useless. Good afternoon, our dear students, and today we are talking about next topic of our gastroenterology lecture course in internal medicine. This topic is chronic hepatitis. Chronic hepatitis represents a series of level disorders of varying causes and severity in which hepatic inflammation and necrosis continue at least 6 months. Milder forms are non-progressive or only slowly progressive, while more severe forms may be associated with the scarring and architectural reorganization, which, when advanced, lead to ultimately to cirrhosis. Older classification of chronic hepatitis divided all chronic hepatitis which should last more than 6 months, and despite they have similar features with acute hepatitis are based on pathological classification. So they divided. So chronic persistent hepatitis, lobular hepatitis, and chronic active hepatitis with mild severe necroinflammation. But new classification is based on the cause, the grade, which is similar to histological assessment, and the stage depending on degree of fibrosis. By the cause, we can divide all chronic hepatitis on chronic viral hepatitis caused by hepatitis B, B plus D association, and C. Autoimmune hepatitis, including several subcategories based on serological distinction, drug-associated chronic hepatitis, and a category of unknown cause or cryptogenic chronic hepatitis. By the stage of the chronic hepatitis, which reflects the level of progression of the disease, is based on the degree of hepatic fibrosis. When fibrosis is so extensive that fibrocepta surround parenchymal nodules and alter the normal architecture of the liver lobule, the histological lesion is defined as cirrhosis. Staging is based on the degree of fibrosis as categorized on a numerical scale from 0 to 6 or from 0 to 4, depending on which scale you use, or histologic activity index or METAVIR index. How to calculate the score you can see on actually the table present on this slide, depending on presence or absence or in severity of periportal, intralobular, or focal cirrhosis and portal inflammation. The stage of chronic hepatitis will be established. By the grade. Grade is histological assessment of necroinflammatory activity is based on examination of the liver biopsy. An assessment of important histological features includes the degree of periportal necrosis and the disruption of the limiting plate of periportal hepatocytes by inflammatory cells, so-called piecemeal necrosis or interface hepatitis. The degree of confluent necrosis that links or forms bridges between vascular structures, between portal tract and portal tract, or even more important, bridges between portal tract and central vein, referred to as bridging necrosis. The degrees of hepatocyte degeneration and focal necrosis within the lobule, and the degree of portal inflammation. Histological activity assessment is present really good on METAVIR staging system, where you can see the, depending on the stage, more severe stage is more severe fibrotic changes. You can see clearly on this slide present. Several scoring systems that take these histological features into account have been devised, and the most popular are the Histologic Activity Index, used commonly in the United States, and the METAVIR score used in Europe. Based on the presence and degree of these features of histological activity, chronic hepatitis can be graded as mild, moderate, or severe. FibroScan is a modern, useful test in almost any patient in whom a clinician wishes to stage liver fibrosis. The main drawback of FibroScan testing is that it cannot be performed in all patients, especially in obese ones. Technical limitation of the test preclude its use in patients who have assigned individuals who are morbidly obese and or patients who have large amount of the chest wall fat. Chronic hepatitis B, it's infection that has a worldwide prevalence of around 300 million affected persons. Patients often remain asymptomatic for years, but may unknowingly transmit the infection to others via perinatal, percutaneous, and sexual exposure, or close person-to-person contact, including open cuts and sores. Estimated around 40% of hepatitis B infected patients may develop complications such as liver cirrhosis, liver failure, and hepatocellular carcinoma, which represent the common cause of hepatitis B related deaths. Chronic viral hepatitis, including both chronic and hepatitis B and hepatitis C infection, is responsible for approximately 1 million deaths worldwide and more than 200,000 in the USA currently. What is the clinical presentation of the chronic hepatitis B? During the infectious disease course, you will have a chance to study acute hepatitis, presentation, treatment, but in internal medicine, we rather deal with chronic hepatitis. So patients with chronic active hepatitis, especially during their replicative state, may complain of symptomology such as following. Symptoms similar to those of acute hepatitis: fatigue, anorexia, nausea, mid-upper quadrant pain, or discomfort. If progressive liver disease is present, the following symptomology may appear, such as hepatic decompensation, encephalopathy, somnolence, disturbance in sleep pattern, mental confusion, coma, ascites, GI bleeding, and coagulopathy. The physical examination of the patients of hepatitis B chronic stage of infection can reveal stigmata of chronic liver disease such as following: hepatomegaly or liver enlargement, splenomegaly or spleen enlargement, muscular wasting means loss of muscular mass, especially on lower and upper extremities, palmar erythema is specific or red color of the palms of the patient with liver disorders, spider angiomata, it's dilated small arteries in the form of the spider or the form of the star. Vasculitis, which occurs rarely, but vasculitis is inflammatory changes of the wall of vessels in patients with different disorders, including hepatitis. Chronic hepatitis B infection is a dynamic process, so the natural history of this disorder can be schematically divided into 5 phases, which are not necessarily sequential. First phase is immune tolerant. It's characterized by hepatitis B E antigen positivity, high levels of replication of the virus, reflected by the high levels of serum DNA of hepatitis B, normal or low levels of aminotransferase, mild or no liver necroinflammation, and no or slow progression of fibrosis. During this phase, the rate of spontaneous loss of HB antigen is very low. This first phase is more frequent and more prolonged in subjects infected perinatally or in the first year of life. Because of high level of viremia, these patients are highly contagious. The second phase, immune reactive HB antigen positive phase, characterized by positive HB antigen data, a relatively low level of replication compared to the immune tolerant phase, increased or fluctuating levels of aminotransferases, moderate or severe liver necroinflammation, and more rapid progression of fibrosis compared to the previous phase. This phase may occur after the several years of immune tolerance, partial breakdown of tolerance, and is more frequently and more rapidly reaches in subjects infected during adulthood, parallel in maturation of specific anti-hepatitis B immunity. It may last for several weeks to several years, and the rate of spontaneous HBe antigen loss is enhanced. This phase ends with a seroconversion to anti-HBe. Third phase is inactive HBV carrier state. May follow seroconversion from HBe antigen to anti-HBe antibody. It's characterized by very low or undetectable serum DNA levels of hepatitis B and normal serum aminotransferase. A minimum follow-up of 1 year with ALT levels at least 3-4 months, and the serum DNA levels is required before classifying a patient as an active HBV carrier. ALT levels should remain persistently within the normal range according to traditional cutoff values, and DNA should be below 2,000 units in milliliter. Some inactive carriers, however, may have DNA levels greater than 2,000 international units in milliliter, accompanied by persistently normal ALT levels. Patient with DNA levels less than 200 or 2,000, and elevated ALT levels should be usually advised to undergo liver biopsy for the evaluation of the cause of liver injury. As a result of immunological control of the infection, the inactive HBV carrier state confers a favorable long-term outcome with a very low risk of cirrhosis or carcinoma in the majority of the patients. First stage is HB negative chronic hepatitis B may follow seroconversion from HBe to anti-HBe antibodies during the immune reactive phase and may develop after several years or decades of the inactive carrier state. It represents the later immune reactive phase in the natural history of the chronic hepatitis B infection. It's characterized by periodic reactivation with a pattern of fluctuating levels of HBV DNA and aminotransferases and active hepatitis. This patient with HBe antigen negative and harbor of predominance of HBV variants with nucleotide substitutions in the precore or and basal core promoter regions that are hence unable to express or express low levels of HBe antigen. HBe negative chronic hepatitis B associated with low rates of prolonged spontaneous disease remission. Fifth stage is the HBs antigen negative phase. After HBs loss, low level of replication of the virus may persist with the detectable HBV DNA in the liver. Generally, DNA of the virus is not detectable in the serum, while anti-HBC antibodies with or without anti-HBs are detectable. And HBs loss before the onset of the cirrhosis is associated with improvement of the outcome with reduced risk of cirrhosis, decompensation of or appearance of hepatocellular. And I should remind you that HBe antigen is the core on antigen in the core of the virus, and HBs antigen is the antigen to the surface of the virus. Clinical terms we used in HBV infection patients. It can be defined chronic hepatitis B, which is a chronic neuroinflammatory disease of the liver caused by persistent more than 6 months hepatitis B virus, can be, as we say, HB positive antigen or negative. Inactive HBs or surface antigen carrier state without significant ongoing necroinflammation result hepatitis B without further virological, biochemical, or histological evidence of active virus infection or disease, which is really rare. Acute exacerbation or flare of chronic hepatitis B, intermittent elevation of aminotransferase activity to more than 10 times the upper limit of normal and more than twice the baseline value. Reactivation of hepatitis B, it's reappearance of active necroinflammatory disease of the liver in a person known to have the inactive HBs carrier state or resolved hepatitis B. HBe antigen clearance, it's loss of these antigens in a person who was previously HBe positive. So absence rather, yes, or loss is not correct word in this case. And seroconversion state, it's absence of HBe or core antigens and detection of anti-HBe antibodies to the virus. Serological markers for the hepatitis B, there are several ones, and we have, as we say, core antigen and surface antigen and anti-HB antibodies. So if a patient have HBs or surface antigens can appear in case of acute or chronic infection. Anti-hepatitis B core immunoglobulin M can be found in the blood of the patient in case of acute infection. Hepatitis B core or E antigen appears in case of high intensive infection of the patient with hepatitis B. Anti-HBC or antibodies to the surface of the virus expresses the immune state of the patient. Anti-HBC immunoglobulin G and HBs antigens appears in case of the chronic infection, and anti-hepatitis BC immunoglobulin G and anti-HBC appears in case of resolved infection for hepatitis. As you can see on the table present here, as long as hepatitis infection B viral infection exists, there are some changes in the parameters which may help you to make a diagnosis. So if we talk about alanine transferase, ALT levels will be high in the acute state, and with the time, if there is no reactivation, like on the present by this peak of the level of ALT, usually they used to be on the one elevated, but not on the one level. If we talk about hepatitis B core antigen, their proportion is higher during the active state, during the replication of the virus. And when or if this replication is stopped, we have seroconversion or changing to immune state and appearance of anti-HBe antigens. The same story with DNA of the patient. DNA of the virus. As long as replication continues, DNA will be found in the patient's blood. When it stops, no DNA. HBs antigen or surface antigen, high concentration will be found during replication or in acute infection. High but stable concentration we can see during chronic phase. In case of the serum conversion, means absence of the replication and quantity, in decreasing of the quantity of viral load in the body of the patient. These levels will decrease with the time. Immunoglobulin M represents in immunity acute phases of infection, hepatitis B or others. So they will be high, but they will not appear from the first several months of infection. It took time for immunoglobulin M to appear, so they appear later, usually after 4 months of acute infection, and they are high during this acute phase. During the chronic phase, you can find them, but the level of these immunoglobulins will depend on the rate of viral load in the body. Chronic hepatitis B disease categorized into, as we say already, HBe or core antigen positive and HB core antigen negative diseases. Subtype wild type or positive disease. In this subtype, patients have mild to moderate elevation of aminotransferases, less than 5 times of normal ranges. The LT levels are usually higher than AST levels. Extremely high levels of LT can be observed during exacerbation or activation of the disease, and they can be accompanied by impaired synthetic function of the liver. Means decreased albumin levels, decreased bilirubin levels, and prolonged prothrombin time due to decreased level of protein synthesis. HBV DNA levels are high during this phase. Surface and anti-core immunoglobulins G and M in case of reactivation identified in the serum. If AST levels are higher than ALT, the diagnosis of cirrhosis must be considered. And subtype of chronic HBV core antigen negative disease, which is not wild as first one. Note that also that result is negative at the stage of core antigen, and core antigen negativity can be associated with the greater DNA replication and more rapid disease progression in patients who carry mutations in either the precore or basic core promoter regions of HBV genome. Let's remind a little about liver function test. Let's refresh a little our knowledge. Yes, so alanine aminotransferase, or ALT called, it's an enzyme found mostly in the cells of the liver and kidney. Much smaller amounts of it and can be also found in the heart and the muscles. Normally, AST levels in the blood are low, but when the liver is damaged, ALT is released into the blood and the level increases. So ALT is a marker of liver cells damage. Comparing with AST, which is aspartate aminotransferase and enzyme found in cells throughout of the body, but mostly in the heart, liver, and to less extent in the kidneys and muscles. In healthy individuals, levels of AST in the blood are low. When liver muscle cells are injured, they release AST into the blood, and AST, however, is not specific for the liver and may be increased in conditions affecting other parts of the body. For example, it can be myocardial infarction or acute chronic kidney failure, or severe trauma with damage of the big groups of muscles. GGT, or gamma-glutamyl-transferase, is an enzyme that is found in many organs throughout the body. The highest concentration found in the liver. Usually the first enzyme to rise in the blood when any of the bile ducts that carry bile from the liver or to the intestines becomes obstructed. GGT levels are sometimes increased with the consumption or even small amounts of alcohol and may be used in evaluating someone for acute or chronic alcohol abuse. This test is not very specific for the liver and is useful in differentiation between various causes of liver damage. Also, you should know that sometimes often medication, for example, inhibitors of angiotensin converting enzyme, can lead to elevation of this enzyme in the liver function test. Alkaloid phosphatase is an enzyme found in the several tissues throughout the body. In the blood samples of healthy individuals come mainly from the liver, with most of the rest coming from the bones. Elevated levels of ALP in the blood are most commonly caused by liver disease, bile duct obstruction, gallbladder disease, or bone disorders. In the liver, ALP is found on the edges of the cells that join to form the bile ducts, tiny tubes that drain bile from the liver to the bowels, where is needed to help digest fat in the diet. ALP in the bone is produced by special cells called osteoblasts that are involved in the formation of the bone. Each of the various tissue types produces distinct forms of ALP called isoenzymes. So LP is the marker of bone problems and rather gallbladder or bile obstruction problems than hepatitis, if it's not cryptogenic, for example, hepatitis, of course. Not all patients with chronic hepatitis B infection have persistently elevated aminotransferases. Patients in the immune tolerant phase and inactive carriers have persistently normal ALT levels, while a proportion of the patient with core-negative hepatitis B chronic infection may have intermittently normal ALT levels. Therefore, appropriate longitudinal long-term follow-up is crucial. Anemia due to shortened red blood cell survival period is an infrequent finding, although hemolysis may be noted. Thrombocytopenia is a rare finding. Patients with the severe hepatitis experience a prolongation of the international normalized ratio. The assessment of the severity of the liver disease should include biochemical markers, including ALT, AST, GGT, alkaline phosphatase, bilirubin levels, and serum albumin and globulins, blood counts and prothrombin time, and hepatic ultrasound. Usually, ALT levels are higher than those of IST. However, when the disease progresses to cirrhosis, the ratio may be reversed. Serum albumin and globulins requires to evaluate synthetic function of the liver and severity of the damage. Blood counts and prothrombin time, the same story, it's synthetic function of the liver. Hepatic ultrasound help to understand severity of fibrosis and the damage of the liver cells. Liver biopsy, percutaneous or laparoscopic, is the standard means of assessing the severity of disease in the patient with features of chronic active liver disease. Also, the liver biopsy is not indicated for patients with acute hepatitis B infection. The findings in the acute phases are predominantly lobular with degenerative or regenerative hepatocellular changes, as well as accompanying inflammation. Necrosis may be predominantly central lobular. The hallmark of chronic hepatitis B infection is lymphoid inflammation, mostly involving the portal tracts. However, occasion on concealment bodies are seen in the lobule. Hepatocytes that distend with the viral particles may acquire an unusual ground glass appearance on hematoxylin and iodine stain. Ground glass cells are seen in approximately 7 to 75% of livers affected by chronic hepatitis B infection. Here you can, on these pictures, you can see the mild chronic hepatitis, and you can see that structure, or rather architecture of the liver is not as it should be. There are many inflammatory cells around central and portal areas. On the picture B, we can see mild portal and perilobular fibrosis, central lobular fibrosis around central vein, and here this infiltration of inflammatory cells consists from lymphocytes and plasma cells, so with wild interface hepatitis in the portal zone. 3 criteria for treatment prescription are used: serum DNA levels of hepatitis B, serum ALT, and histological grade and stage. Patients with moderate to severe active necroinflammation of fibrosis in the liver biopsy with DNA above 2,000 units of milliliter and ALT above the upper limit of normal. Age and comorbidities also affect the decision to treat and with which agent. Also should be treated patients with hepatitis B chronic infection if cirrhosis is present, and treatment should be given independently of the level of ALT or DNA. Patients with decompensated cirrhosis can also be treated with the oral antiviral agents, but liver transplantation may be required. Immunotolerant patients, usually young with persistently normal ALT DNA levels without evidence of liver disease and without a family history of cirrhosis or hepatocellular cancer, do not need therapy, antiviral, but must receive follow-up. The aim of treatment of this in the seroconversion of HBe antigen when present to anti-HBe antibodies, and the reduction of DNA up to 400 units in the liter or less, measured by the sensitive PCR techniques. In addition, normalization of serum ALT, histological improvement, inflammation and fibrosis, and loss of surface antigen reflects as a good response. If core antigens disappears, remission is usually sustained for many years. Patients usually remain HB surface antigen positive, but there is a small but incremental loss of this antigen in the blood per annum. What kind of antiviral antigen with agents or medication we can use for treatment of chronic infection of hepatitis B? Usually, pegylated alpha interferon gives response around 45%, and after 48 weeks of the treatment, it's the most widely used agent antiviral. Patients with high serum aminotransferase values who are younger with viral loads respond the best. Small viral load, I'm sorry. Patients with concomitant AIDS respond poorly, and those with cirrhosis should not receive interferon. Side effects of treatment are many, with an acute flu-like illness occurring 6 to 8 after the first injection. This usually disappears after subsequent infection, but malaise, headache, and myalgia are common. Depression, irreversible hair loss, and bone marrow depression and infection may also occur. The platelet count should be monitored, and the older patient, HB core antigen usually disappears or changes due to changes in the viral genome. Oral therapy are represented by the three most frequently used. First one is entecavir, is very effective and reduces DNA levels quickly, and there is a little viral resistance. Serum DNA levels becomes negative in more than 60% of the patients, and 90% of the patients with negative to antigen to core antigen negative result by 48 weeks. It should not be used in patients with lamivudine-induced mutations, and that can be used if tenofovir mutation have occurred. Tenofovir is also very effective, has a similar potency to entecavir, and as yet no resistant mutants have been described. It's used for HIV patients with HB infection. It can also be used in patients with lamivudine mutation, but not on its own for adefovir mutation. Lamivudine, given orally, usually is and well tolerated. However, by 4 years, 80% develop viral resistance to this drug, and which itself can cause hepatitis, but drug hepatitis in this case, yes. Lamivudine monotherapy is no longer recommended. The duration of all treatment is probably lifelong and is still being assessed depending on severity, presence, absence of seroconversion, and individual response. Possible outcomes of chronic hepatitis B infection can be in bigger part of the patient, it's cirrhosis in 5 years, and also it can be liver failure in the quarter of the patient, or less frequently it's hepatocellular carcinoma, which lead to death if no liver transplant will be given for a patient. Chronic hepatitis C is an infection caused by the hepatitis C virus that attacks the liver and leads to inflammation. The World Health Organization estimates that about 71 million people globally have chronic hepatitis C, and more than 300,000 dying from the infection, primarily due to cirrhosis and hepatocellular carcinoma. The WHO estimated that in 2016, approximately such big amount of people will died from hepatitis C, and antiviral medicine can cure more than 95% of persons with hepatitis B infection, thereby reducing the risk of death from cirrhosis and liver cancer, but access to diagnosis and treatment is very low. You can see on the picture how it looks like the virus C, comparing with virus B, it's not DNA but RNA virus. I should remind you that hepatitis B is DNA virus surrounded by the nucleus contains RNA surrounded by the capsid, and around the capsid is envelope with glycoproteins on its surface. 7 genotypes of hepatitis C infection identified, and many subtypes are present. Depending on the genotype, treatment will be prescribed for the patient, and this response can be predicted depending on genotype. As you can see, for example, in the Africa, we have many 1, 2nd, and or 4th genotype. In South Africa, it's mostly 5A genotype. In the Russia, it's first A, B, 2A, or 3E. Asia can be 1B, 3B, 5A, but in the China it's 1B, 2A, or 6A. In Europe, we can have many of, but for example, 2C, which is present in Europe, is absent in the South America, or even in North America too. 85% of hepatitis C infection is chronic, and only 15% of this chronic infection is resolved. Hepatitis C establishes a chronic state in the most infected patients, and risk factors of progression are older age, alcohol use, and coinfection with AIDS or hepatitis B, which is not so rare. So in 20 years, 75 to 85% with chronic hepatitis, and in 30% of them, in 25 years, cirrhosis will be established, and from 2 to 7% of this cirrhotic patient, hepatocellular carcinoma can be established also. Chronic hepatitis C infection induced immune dysfunction such as impaired T cell function and inefficient antibody responses, metabolic disorders such as hepatic steatosis, iron accumulation, and insulin resistance, often associated with the type 2 diabetes. More importantly, C virus is one of the major etiologies of chronic hepatitis and progressive liver fibrosis that lead to development of lethal complication as cirrhosis or hepatocellular carcinoma. C infection can induce chronic hepatic inflammation with varying activity, which causes progressive liver fibrogenesis and leads to development of cirrhosis. First, metabolic retrogramming includes disturbances of lipid metabolism and mitochondrial dysfunction. Several studies highlight the role of the C core protein in steatosis and C nodal development, as well as in insulin resistance, which is accompanied with the intrahepatic lipid accumulation. C core protein was also shown to contribute to mitochondrial damage by impairing mitophagy. The resulting oxidative stress is regarded as a key trigger of carcinoma initiation and development. Hepatitis C viral proteins were reported to have both pro-apoptotic and anti-apoptotic properties. Viral proteins can impact on the epithelial-mesenchymal transmission pathway, which promotes fibrogenesis, tumor development, and metastasis. Most patients with hepatitis C infection do not have abnormal physical examination findings until they develop portal hypertension or decompensated liver disease. One exception is patients with an extrahepatic manifestation of hepatitis C infection, such as porphyria cutanea tarda or necrotizing vasculitis. Signs of infection, signs of decompensation or of hepatitis C chronic infection includes the following: pulmonary edema, dupituitarian contracture, asterix, leukonychia, or clubbing, ecteric sclera, temporal muscle wasting, enlarged parotid cyanosis, Fetor hepaticus, which is non-pleasant smell, like sweety smell from the patients, gynecomastia and small tasted in males, paraumbilical hernia sites, caput medusa, hepatosplenomegaly, abdominal breath, ankle edema, scan body hair, spider nevi, petechiae, excoriation due to pruritus. Other common extrahepatic manifestations include cryoglobulinemia, membranoproliferative glomerulonephritis, idiopathic thrombocytopenic purpura, or lichen planus. You can see it here, squamous changes on the skin. The most recent recommendation of the American Association of the Study Liver Disease and Infectious Disease of America includes several recommendations and follow-up. Initial testing for hepatitis C, hepatitis C antibody test. If result is positive, confirm current infection with a sensitive RNA test. In case of negative and hepatitis C antibody test with clinical suspicion of liver disease, patients should be tested for hepatitis C RNA or follow-up testing for hepatitis C antibody if hepatitis C exposure occurred within the past 6 months. Consider testing for RNA in immunocompromised individuals. Reinfection after previous spontaneous or treatment-related viral clearance, in this case, obtain the initial RNA testing of the patient because antibody test is expected to be positive. If before the initiation of the viral therapy, should be obtained quantitative RNA testing to document baseline viral load. Selection of the most appropriate antiviral regimen, depending on the genotype, should be made. Positive antibody test with the negative RNA about polymerase chain reaction. In this case, you should inform the patient they do not have evidence of current active infection. All patients with hepatitis C infection are recommended to have an evaluation for advanced fibrosis with the use of the liver biopsy, imaging, and non-invasive markers to aid the decision-making regarding treatment strategies and to determine whether additional measures for the management of cirrhosis should be initiated. The WHO recommends nucleic acid testing for qualitative and quantitative RNA detection, as well as for tests of cure at 12 to 24 weeks following antiviral treatment completion. In areas with limited resources, the WHO suggests using the aminotransferase platelet ratio index or the fibrosis score for evaluating hepatic fibrosis rather than other non-invasive tests that requires resources. You can see them on the picture. This models and serology screening involves an enzyme immunoassay. These assays are 97% specific but cannot distinguish acute from chronic infection. A rapid antibody test for hepatitis C is available. The recombinant immunoblot assay is used to confirm hepatitis C infection. The other baseline studies include complete blood count with differential, international normalized ratio, liver function test, calculated glomerular filtration rate to evaluate and prevent expected complications, thyroid function study, screening test for co-infection with human immunodeficiency virus of hepatitis B, screening for alcohol, drug abuse, or depression, hepatitis B testing with hepatitis B surface antigen, as well as surface antibody and antibody against core antigen. Serum pregnancy testing before initiation of the treatment in the woman of the childbearing age. CBC usually demonstrates thrombocytopenia in 10% of patients. Low thyroxine levels are found approximately 10% of patients, and stress testing may be necessary in appropriate patients. An ophthalmological examination may also be necessary. For hepatitis C infection, the same story that ILT can be high in first months of infection, but with chronization, levels of ALT becomes normal or low, but can have intermittent low character. So sometimes okay, sometimes higher than normal or close to normal, then again appear depending on activization or decreasing of replication of the virus. Anti-hepatitis V antigens are absent or hardly being observed in patients with acute infection, but with the time, the quantity of them will be high till the resolution, which is never come. If hepatitis C antibody anti-hepatitis C test result is non-reactive, there is no detectable antibody to hepatitis C, and unless there are special circumstances, just such as recently exposed, immunocompromised, or other special medical circumstances, the person can be considered never affected and therefore suspectable. If anti-HCV is reactive, this indicates either current HCV infection, past viral infection that has resolved, or false positive result. Directive test results should be followed by NAT for their HCV RNA. If HCV RNA is detected, this indicates current hepatitis C infection. If HCV RNA is not detected, this indicates either past infection that has resolved or false positive anti-HCV test result. As with a non-reactive HCV result test, the person with a negative RNA test who has a known or expected exposure to hepatitis C within the prior 6 months or with other medical issues that may impact test results should be followed up. Hepatitis C genotyping is helpful for predicting the likelihood of response and duration of the treatment, can be performed by direct sequence analysis, reverse hybridization of genotype-specific oligonucleotide probes, or restricted fragment length polymorphism. In addition to hepatitis C genotype, a growing body of research indicates that patients' genetics play a role in the response to treatment. Liver biopsy is not considered mandatory before the initiation of the treatment for hepatitis C, but it may be helpful for assessing the activity and severity of hepatitis C virus-related liver disease. However, some experts recommend biopsy only in the following situations. The diagnosis is uncertain, other infection or disease may be present, the patient being considered for treatment has normal liver enzyme levels and no extrahepatic manifestations. The patient is immunocompromised. Lymphatic infiltration, moderate degrees of inflammation, necrosis, and portal bridging fibrosis are noted in the hepatitis C. Regenerative models are seen in the patient with cirrhosis. Some patients also may have findings indicative of hepatocellular carcinoma. The most important aspect of evaluation of the patient with hepatitis C infection is determining whether or not he or she has cirrhosis. This is the most important part of the staging because there are specific guidelines defining how one should be proceeded with the patient with cirrhosis in respect to screening them to each 2 to 3 years for esophageal varices and portal hypertension, and putting them into program with the cross-sectional imaging, ultrasound, computer tomography, or magnetic resonance imaging every 6 to 12 months for monitoring risk of the liver cancer. There are currently 2 alternative methods to stage liver fibrosis and few other modalities that are under development. One available alternative is serum testing. A perfect example of a serum testing is the AST platelet ratio index, which is the AST over control divided by the platelet count. Patients with the high index usually have significant scarring or cirrhosis. The second most widely used test for the liver fibrosis, not only in the United States, are the FibroSure or HEPA score. Both tests are very good in terms either sensitivity and specificity in diagnosing cirrhosis, but similar to biopsy, they are not as accurate for exact identification of intermediate stages of the disorder. Hepatitis C became a curable disease with the use of antiviral agents. Treatment for chronic disease is based on the guidelines, and they are updated very often, and previously proposed that patients, because of all patients cannot receive treatment immediately, a priority should be given to those with the most urgent needs. The recommendation includes the following: patient with advanced fibrosis those with compensated cirrhosis, liver transplant recipients, and those with severe extrahepatic complication are to be given the highest priority for treatment. Based on available resources, patients at high risk for liver-related complication and severe extrahepatic hepatitis complication should be given a high priority for treatment. Treatment decisions should balance the anticipated reduction in transmission versus the likelihood of reinfection in patients whose risk of transmission is high and whom hepatitis C treatment may result in reduction in transmission. Antiviral therapy for chronic hepatitis C should be determined on the case-by-case basis. However, treatment is widely recommended for patients with elevated serum aminotransferase levels who meet the following criteria: older than 18 years, positive hepatitis C antibody and serum RNA results, compensated liver disease, acceptable hematologic and biochemical indexes, willingness to be treated to adhere to treatment requirements, and no contraindication for treatment. The further criterion is liver biopsy findings consistent with the diagnosis of chronic hepatitis. Viral load suppression reduces the risk of hepatitis C, liver morbidity, and mortality. Current treatment is combination therapy with the pegylated interferon, which is interferon with polyethylglycol tail, and ribavirin. For genotype 1 only, pegylated interferon ribavirin is combined with either of two protease inhibitors, tilaprevir and boceprevir. Other drugs, protease inhibitors, cyclophosphamide inhibitors, new types of interferon, and ribavirin analogs are all being developed, which will change the treatment algorithms in the future. Treatment duration with combination of interferon and ribavirin alone is 12 months for genotypes 4 and 6, and 6 months for genotypes 2 or 3, and as short as 6 months for some genotypes 1 patient receiving triple therapy. Patient infected with human immunodeficiency virus and hepatitis C are at risk for accelerated liver fibrosis and should be offered antiviral treatment. Coinfection in person should be treated and treated the same as those without AIDS. Once any interaction with antiretroviral agents have been identified and managed daily, diclofenac plus sofosbuvir with or without ribavirin is recommended regimen when an antiretroviral regimen changes can be made to accommodate alternative hepatitis C direct acting antiviral medication. However, the combination of lidipasvir and with sofosbuvir for 8 weeks is not recommended regardless the patient baseline RNA levels. Hepatitis D virus is a virus that requires hepatitis B virus for its replication, affects globally nearly 5% of patients and who have a chronic infection with hepatitis B. Several geographical hotspots of high prevalence of D infection exist. It's usually Moldova, Mongolia, countries on the Western and Middle Africa. Population that are more likely to have B and D co-infection include people who inject drugs, indigenous population, and recipients of hemodialysis. Co-infection is considered the most severe form of the chronic viral hepatitis due to more rapid progression towards liver-related death and hepatocellular carcinoma. This is a relatively infrequent chronic hepatitis, but spontaneous resolution is rare. Between 60% of patients will develop cirrhosis and more rapidly than if B infection will be low. Currently, treatment success rates are generally low. Hepatitis D infection can be prevented by immunization to hepatitis B. D infection is diagnosed with high levels of immunoglobulin and immunoglobulin M, immunoglobulins to HDV virus, and confirmed by detection of RNA of hepatitis D virus in the serum. Current guidelines generally recommended pegylated interferon alpha for at least 48 weeks, irrespective on the treatment response of the patient. Autoimmune hepatitis one of significant form of hepatitis 2, approximately 20% of patients is autoantibody negative, means there is no circulating autoantibodies to nucleus content. Always consider drug-induced autoimmune hepatitis like liver injury. If discontinuation of the drug doesn't improve condition, so consider then that it's autoimmune, not drug related. Presence at least one other autoimmune disease in fairly common young patient with autoimmune hepatitis is around to 44%. Patients should be screened for celiac disease and thyroid disease. A part of physiology of this form is the appearance of autoantibodies due to immune system response changes to the liver cells and damage of the liver cells by these antibodies and the following of them inflammatory and fibrotic changes. Clinical presentation usually have highly variability from subclinical to disease to acute liver failures. Symptoms of chronic inflammation include fatigue, myalgias, arthralgias are common, typically hepatocellular pattern of the liver injury. Third cholestatic pattern has been reported. Immunoglobulin G typically elevated up to threefold upper the limit over the upper limit of the normal. If the diagnosis of autoimmune hepatitis is suspected and depends on 4 factors: presence and titers of autoantibodies, usually antinuclear, anti-smooth muscle antibodies, immunoglobulin G elevation, classical histological findings, and exclusion of other etiology of hepatitis. It's because it's a rather diagnosis of exclusion. Strong indication for immunosuppressive diagnosis should be in case if ALT levels more than 10 or 5-folds than normal upper limit, certain histological findings specific for autoimmune hepatitis as bridging, for example, necrosis. If mild laboratory, clinical, and histological findings, no great data regarding need for treatments. So therapy is highly individualized for a patient. The usual therapy is prednisolone with or without azathioprine, which is immunosuppressant regimen until respond, then gradually tap steroid till the low or till the low dosages or to discharge of the treatment. Thank you for your attention. As usual, you can put your questions under this lecture, or you can send me them in the private via Telegram or email. Thank you and goodbye. Have a good day.